Okay, so for week 4, oxygenation, I'm gonna just go over the most important stuff for this one, and then the rest of the document is available. This one also comes with some questions attached to it, like towards the end. I think 10 questions with choices. So I'll go over the main things for this one. So this is, I believe, the respiratory. Are they still having that be its own individual quiz for you guys, or is it just included into sepsis? Let me see. Mhm. Oh, okay. The document bigger? Oh yeah. Okay. Part of sepsis, huh? I think that's still the same test, yeah. Still the same idea. Okay. Uh, so some of the stuff that they go over is just the oxygenation. Like when someone's struggling with their oxygenation, has a low SATO2, some of the early findings. So one of the first signs could be with a neuro, so that's why they always try to drill in if the patient's like acutely confused, you should check the vitals, see if their O2 is off. Maybe they're developing an infection or something and they're older. But one of the things to look into, especially if you also see some of the side effects like their shortness of breath, they have accessory muscle use, etc. No, you won't be like hard tested on this part here, but it's good for you to know, like the early findings. But that's something they've been pushing on from the beginning. And the late findings is when the person is starting to fall unconscious, lose consciousness, and turn blue. So you want to obviously catch it when it's right here. So that's why the some of the neuro stuff might be the restlessness could be a good thing to keep in track. They'll also probably have higher heart rate, lower SATO2, higher heart rate. So whenever the vitals are a little bit off, it's worth investigating a bit more. And then this is just a review on some of the interventions for general oxygenation. So you guys know the things they try to drill into you is head of the bed up immediately. If um, they need O2, turn it on. Uh, Try to have it already set up by the bedside so that you don't have to go to the supply room to get the nasal cannula. And then just like a general tip, check if it's actually on or connected. It does happen where it gets disconnected from the Christmas tree or it falls off on them. Pull it out or it just kind of comes off a little bit. Um, some of the other stuff that they always kind of bring up is just your incentive spirometer and your turn cough deep breathe, general breathing treatment stuff. So stuff that you guys are already familiar with and understand. So all of this stuff you guys kind of have the general idea. So you guys 100% are very comfortable or have at least seen enough of the oxygenation stuff and testing and to kind of get the general idea with the early interventions and like what to do. But if once all of this starts to fail, that's when the patient starts going into more of an acute respiratory failure. So that's going to be the main focus for this topic. So acute respiratory failure, not being able to have adequate gas exchange. So some of the ABG stuff to kind of look at is you'll have your PaO2, which is between 80 to 100 for normal, like under 60, less than 60. A buildup of CO2, you guys know 35 to 45 for that. You'll see it as above 45. Right here, 40, but above 45 to 50 would be like the definition of hypercapnia. And then some of the general ventilatory failure stuff. So there's the different types of failure when it comes to acute respiratory failure, and this is important for you to keep track of uh for the test. For sure, you're gonna want to know the difference. So, two ways that someone could have inadequate gas exchange would be from ventilatory failure or oxygenation failure. Ventilatory refers to the ability to breathe in and out. So this is referring to either trauma, like chest trauma, for example, where the person cannot breathe in and out. They physically cannot breathe in and out. Uh, some things like narcotics, overdose on narcotics, so they have respiratory depression. Their respirations are so low that they are not ventilating enough, so not breathing in and out enough. People with neurologic conditions like multiple sclerosis, botulism, um, Guillain-Barré disease syndrome, all that stuff, anything that impedes your ability to weakens the muscles or im the gets in the way of you being able to breathe in and out. So that's ventilatory failure. Yeah, so mechanical, yeah. Ventilatory is mechanical. Really just are they able to breathe in and out? Inability to breathe in and out. Anything else falls more under oxygenation failure. So some of the signs here, main thing is low respiration rates and effort. So literally just are they able to breathe in and out appropriately? And then again, some of the causes here, blunt trauma, respiratory depression from narcotics, uh, conditions that prevent you from utilizing your muscles effectively. Even something like low electrolytes that might be impeding with ability your diaphragm's ability to contract properly. Oh, you're good. Spinal cord injury, etc. While oxygenation failure is this is now happening inside of the lungs, in the bronchioles, in the alveoli. So oxygenation failure is when you're unable to have that exchange, that appropriate exchange. And some of the causes here include like acute lung injury from like a severe burn, sepsis. Sepsis can then leads to, inflammatory response. That inflammatory response can then affect the alveoli and decrease the ability to diffuse lung cancer, of course, and pulmonary embolism. So anything where there's a damaged uh, alveoli, which damage to the lungs in general. So a pneumonia could cause it. COVID, ARDS, the acute respiratory distress syndrome, which usually comes from inflammatory, so from an infection of some kind. Or it could even come from like a near drowning incident. Near drowning incident, you'll have direct. like internal lung damage. So this is like outside blunt chest trauma. Oxygenation failure can occur from like internal lung trauma as well. So near drowning or anything that acutely hurts the inside of the lungs, like a pulmonary embolism. So the key thing for this one, it's gonna have a lot of the same signs because overall it's still issues with getting oxygenation out. The key thing is going to be that with oxygenation failure, your SATO2 is not going to maintain even with supplementation because the issue is the ability to even make the exchange to begin with. So if you're struggling to make the exchange to begin with, you're not going to, even if you're getting more O2, you're not going to be making the exchange any faster, right? Um, any questions so far? And is there any questions that you want to know ahead of time or anything in particular that you want to know before we move on? Okay. So we went over ventilatory versus oxygenation. So you'll have some questions that will directly ask you, is this oxygenation failure versus ventilatory failure? Yeah, of course. So just keep that in mind that you will have questions that ask you like, is this oxygenation? Is this ventilatory? So again, the key difference with oxygenation failure is SATO2 is not going to help you as much because the issue is that the exchange. So doesn't matter. So you can think of it like there's a ton of food in the refrigerator, but you're like, even if there's a lot of food in the refrigerator, you're not going through it fast enough. Doesn't matter that you keep stocking it up because you're still eating at the same pace. So it's not helping you eat more because you're eating at your same pace. Having a little bit extra doesn't change your speed. While here, this is more like you just don't have food at all. So ventilatory failure, just keep in mind the causes. Don't hard memorize, but just get that general idea in. This is difficulty breathing in and out, chest trauma. Oxygenation failure is direct internal lung damage, inability to make the O2 exchange. Okay, so speaking of oxygenation failure, that's going to lead up into the refractory hypoxia. So it kind of goes along with it. So this is a patient has low oxygen and it does not improve despite the fact that you have the appropriate oxygenation. So this will be something that they call the 50-50 or the 60-60 rule. This is based on their ABGs, and it's kind of like a guideline for intubation. But keep in mind that obviously for someone that is acutely going down, like let's say it's like on the street and the EMTs and all like the first responders get there, you're not gonna wait for an ABG before deciding to intubate. So in like that like crazy emergency out of nowhere situation, it's more on kind of build going up the bridge. So O2, you put some O2 on, it's not helping. You move on to the next thing, it's not helping, and then maybe you decide to skip a step, go straight into a BiPAP or a CPAP, and then at this point, hopefully you already called the rapid, uh, and they can get ready to maybe intubate, or if you, I guess, yeah, get them ready for intubation, stuff like that.
Diego.
Hmm.
So for the um, for a patient who needs to be intubated. So it's looking at more of how the patient is doing in terms of oxygenation. They're not improving, or they usually kind of like base it more on the, or I would think maybe not. I was just wondering if it's a hard rule that they're kind of still waiting for the FiO2. If it's not improving, they're looking at those levels. But I would think it's just basing on how the patient is doing, right? That they would intubate them.
Yes, so it would be more on how they're doing because you're not gonna wait because you don't want to wait to get the ABGs. It would
Of
just be
course, yeah. Mm.
yeah. But I think where the rule kind of comes in, it's more like if someone is already maybe like getting a lot of support through like a lot of O2 support. They'll do the ABGs just to see how they're doing, and then they're already getting support. They're technically like not in distress. They see maybe they'll go off the ABGs and then make the decision that maybe we need to intubate them based on the ABG, based on this rule. But if it's just like out of like that sudden, because like a lot of this is acute, right? So like acute respiratory failure, a lot of times in that instance, you're not gonna wait for the ABG. You're just gonna do it based on presentation. Uh, yeah.
Thank you. That
So
helps to think of it more on the ABGs, right? Than from what you're so it kind of, I know part of it is also some of it we're seeing that the patient is declining, but also we need something to also tell us, I mean, is their body still fighting it? Because I know intubation introduces a whole lot of other
mhm.
complications, but so the ABGs would be the telling sign then.
Well, like I said, the presentation more than anything. So the ABGs are used still. But like in an emergency, you're not gonna wait for them. You're not gonna wait for the ABGs. You're just gonna go up the chain of command. And then the ABGs would be more like I said, if someone's already already having like O2 support. Like let's say, for example, like someone's going down, you'll go up your thing, so you'll go like nasal cannula, it's probably not gonna you might skip the nasal cannula just based on like how they're presenting. You'll try ambubag, you'll try like, all that stuff. And then you'll non-rebreather. You'll try non-rebreather, that doesn't help. Okay, let's get the ambubag while we're waiting for the BiPAP or the CPAP. And then when they're there, they might do the ABGs as they're trying to stabilize them because as they'll mention that it's like the bridge to ventilation. So maybe they'll do an ABG there and make the determination of this person's gonna need the full on ventilation. Or like I said, they might like depending on their presentation, they might just immediately try to prep the ambu bag and try to prep the person for getting vented. Depending on how they present is probably gonna determine whether they skip get it waiting for the ABGs or not. How stable are they? Uh, because like again, you're not gonna want to wait. You're not gonna want to wait if someone's struggling in like heavy distress. You're not gonna want to wait for the ABG, so you would just go straight into it. But if you're able to kind of stabilize them, that's when you would go off it. So it like for example, let's say you're ambu-bagging them. At that point, the doctor might be like, let's just go straight for venting, or they might be like, let's try the BiPAP CPAP. If they go straight into venting, they go straight into venting, and then they skip the step of ABG. If they decide BiPAP CPAP, then they might be like, okay, let's see if let's pull the ABGs. If they're looking a little bit more stable, we'll wait for the results. If the results tell us it's seems appropriate to vent, we'll vent, or if not, we'll just keep them on this until they fully stabilize, if that makes sense. As for the exact process, I don't know because I never had to do any of this, and I don't think I ever will have to worry about any of this personally. But um, that's what I imagine is kind of like the general idea. So it's not like a hard rule, like you have to get ABGs in order to do it. It's mostly presentation, and I would imagine AVGs is there to make the final call once they're already a bit more stable. If that all makes sense. Let me know if I explained it poorly, or just let me know if you still have more questions. But um, as for the as for the test questions, I think they might provide you ABGs because it's not a real life scenario. So it would just be like here you go, here's the information they give you. Uh, where do you go from there? Thank you. And then here it's kind of like a patho way to think of it. So, um, I mean, it makes sense. If you're not breathing, you're gonna die. But that's pretty much the idea. But it lets you see that connection between some of that metabolic acidosis that happens. So no O2, you go into lactic acidosis. You go into anaerobic, you built up lactic acid, metabolic acidosis, organ dysfunction. And then this refractory hypoxia can lead to full-on respiratory arrest, like straight up, like no more breathing, no more, um, no more attempts, just full-on arrest, which is then a code blue. Okay. Aerobic versus anaerobic metabolism. Aerobic just means you're breathing and you're utilizing air to get ATP, so energy. So that's where the whole Krebs cycle comes in. Um, you really don't need to worry about it. Like you really don't need to worry about it. Anaerobic metabolism, your body doesn't have O2, so it finds ways to create ATP without using O2, without doing the Krebs cycle, and it ends up with lactic acid as a waste product. But anaerobic metabolism is very inefficient, so you don't make enough energy to make up for the fact that you're lacking O2, so you build up a lot of lactic acid as a waste product, and that's where that kind of comes from. Um, yeah, yeah. Um, the Krebs cycle is kind of like it, it's kind of like, I don't know, I'm sure you've probably heard of it, like all the drugs people make, because the Krebs cycle is something that you kind of memorize for like the MCAT to you do like in medical school, but then you never use it because like, well, you really don't have to. But yeah, like it's yeah, you really don't have to know the difference, like at all, like at all. Uh, but then moving on from that, we have acute respiratory distress syndrome, or ARDS. So this is now we're gonna apply some of the stuff that some of the terminology that we know. The main thing to know is this is a inflammatory condition. Okay, so inflammation, it's going to lead to some fluid shifts. So massive inflammation that leads to fluid shifts. And a lot of the time when we think of fluid shifts, the biggest thing that we're thinking about is it going to go to the lungs? And in this case, that's effectively what is happening. So massive inflammation, fluid shifts, lungs. That's not good because then you're struggling to get that exchange going. So right here, it's defined by refractory hypoxemia. So that's this topic we just kind of mentioned. or despite the fact that you're getting O2, it's not helping because this refractory hypoxemia, this is occurring due to this is occurring due to the oxygenation failure. So the inability to make that exchange, um, the inability to make that O2 exchange is the reason for why even the O2 supplementation doesn't help. The VQ mismatch, this is similar to what we learned about with the pulmonary embolism. It's just the inability of ventilation and perfusion of your gas exchange. So, kind of going back to oxygenation failure, that inability to make the exchange because it's all internal. So even though in the ARDS and in oxygenation failure, respirations are happening, it's just the exchange of O2 isn't happening. So pretty much the exact opposite as ventilation failure. Ventilation failure, not as much breathing going on, but exchange is fine, which is why ventilatory failure does a lot better with supplementation. But it's also important to note that with ventilatory failure, depending on how severe it is, supplementation might not be effective solely because they're just not breathing in enough of what you're supplementing. So you're giving them a ton of O2, but they're breathing 3 times per minute. So they're not getting enough O2 anyway. So that's where ventilatory failure can also be intubated, or put on a ViPAP, CPAP for the purpose of getting them to breathe more. So O2 supplementation might not help ventilatory failure very much just because they're not breathing enough for it to make a difference. And then oxygenation failure, supplementation might not help very much because the exchange is improper. So you need to go a bit crazier um, on the interventions. Okay. And then pulmonary edema, like I mentioned, inflammatory, fluid shifts. The biggest thing that we stress about when it comes to uh, fluid shifts is always pulmonary edema, and that's what's happening here. So those are the main things that you're gonna have with ARDS is pulmonary edema, fluid in the lungs, difficulty getting the SATO2 up, even though you're giving them O2, and it's gonna be an oxygenation failure. Okay, so both of these, oxygenation failure and then pulmonary edema. So let's kind of just make this as clear as possible. And then this is basically an oxygenation failure. Okay, here are some possible causes, but don't memorize it. Really do not memorize it. It's the main things that just keep this in mind. It would just be some of the main causes for ARDS is sepsis. And then think about like things like near drowning. You'll probably see some scenarios where that's what's happening. And again, they'll ask you what is the possible failure that goes on with these type of things. So that's where, remember, ARDS is an oxygenation failure. So that's where that goes in. So near drowning, oxygenation failure because you have internal lung damage. And then sepsis is inflammatory and ARDS is inflammatory. So that's that connection there. Okay. We do have the stages listed. I do not recall this coming up, but decent to know kind of the general idea. So here you see the initial phase, inflammation is going to lead to edema initially, and then uh, that's kind of the acute phase. So this is the worst part of it. So that pulmonary edema is the thing causing a lot of the issue. This stage is when it starts to repair. They will still have weakened lung function, but they're starting to make the recovery. And the fibrotic stage is not something that happens with everyone. It just depends on how much damage there is, but this is basically then like the formation of scar tissue, which will then lead to permanent reduced lung function because of that. Like it says here, like they might like if it's really bad, they might just need to be on a vent for longer periods of time. Um, so it's something to think about there. And basically, this is what was happening with the COVID patients. They were having their body was having a severe uh, immune response, so that led to this severe inflammatory response. So that severe immune response is a severe inflammatory response by default. So that led uh, to all this happening here. So it led to the fluid shifts, led to the lungs having difficulty exchanging O2. They needed to be vented. And then they end up with permanent lung damage even after they recover. But that was a very common thing. One of the main reasons they needed ventilation in the ICU for severe COVID cases was because they developed ARDS. Okay. So again, your things to focus on is really just this part here. Like, what is it exactly? Some your manifestations. So again, refractory hypoxemia, this is the definition of it. This is with probably despite is a better word. So a PaO2 under 60, despite the fact that you are supplementing with 60% or more FiO2. So that's your refractory hypoxemia. Again, that's one of your biggest things. Something that you'll see on test questions, Kaplan and stuff like that, is that you'll have if once they do a chest X-ray, they call it a whiteout or a ground glass appearance. Okay. This is a picture so you can see it, but you're not going to be interpreting a chest X-ray. It will just be they will do like a written description of it. And the mention of the pulmonary the wedge pressure is because pulmonary edema could be a heart thing, could be caused by the heart. With ARDS, it's not related to the heart. So the PaWP value will be normal or maybe a little bit low because of the fluid shifts, but it's not due to backup in the heart. So the pulmonary edema is not due to the heart. So the heart, so this would be represented by the PaWP value being normal as opposed to high when you have heart failure, as we kind of went over here, where if it's high, it's either cardiogenic shock, it's left-sided heart failure, etc. And this is just nerdy information here. And I don't think they ask you this, but for a fun fact, I suppose, like it's mentioned here, when you have issues with your heart, you have that pressure buildup, and it's that excess pressure, the hydrostatic pressure that it's kind of like you have too much going on, so it has to go somewhere else. So that's what causes the pulmonary edema with the heart condition, while this is just due to purely due to the inflammatory response causing permeability changes, so it goes so the fluid shifts that way. And I think one of the interesting things about this condition, again, I don't think you're tested on this, but is that uh even though that they'll have like pulmonary edema, it is possible that at the beginning of the condition that you won't hear any lung sounds. As in like you won't hear crackles. You'll hear like clear lung sounds because the fluid shifts um start interstitial. So kind of like how because this is inflammatory, so this is fluid shifts due to not so much oncotic pressure, but kind of that similar concept. Kind of like when you're lacking in albumin, you have fluid shifts. Um, and stuff goes interstitial when you're lacking in albumin. Same kind of concept. The inflammation causes the fluid shifts to start out interstitial, so you're not listening to the crackles in the lungs. You don't hear the crackles in the lungs, but over time it becomes you'll start hearing the lung sounds. But initially, it'll be with ARDS, you will not hear crackles or rhonchi or anything initially. But like I said, I don't think that's tested on at all. But you might see some if you're doing like your own Quizlets and all that stuff, you might see questions where that comes up. But uh yeah. So definitely focus in on some of the interventions here with arts. Let's see. Okay. So if this is a lot of the times due to sepsis or due to infection, antibiotics or whatever works, because obviously COVID is viral. So for COVID causes you need antivirals, not antibiotics. Uh, or a lot of times there's just nothing you can't. There's no like sometimes they just don't. There's nothing you can do. You can't use the antivirals. You can't use antibiotics. Meds for inflammatory because it's an inflammatory condition, so steroids would help there. The BiPAP or CPAP, so uh, non-invasive form of mechanical ventilation. Um, this is mostly used for ventilatory failure etiology, but this is what they say is like the bridge to a bridge to intubation. But the BiPAP CPAP is gonna mostly help with the is for those that are instead in the ventilatory failure camp because like I said, O2 supplementation doesn't help when you're only breathing 2 or 3 times a minute. So I need something to help them breathe. But with but with respiratory or with ARDS, you need something more invasive to actually help out. But this might stabilize them before they need to be intubated. Depends on the situation. But for the most part, these patients will be intubated. So then intubation, some of the indications listed, and again, don't hard memorize it. For the most part, it makes sense, right? But it's all listed here. Again, don't hard memorize it. Some of the stuff to keep in mind, some of the stuff to keep in mind here. This is very important. Just have it available at the bedside, just in case something happens with your vent. But before, you're gonna be ambu-bagging them. They're gonna get the crash cart. It's gonna have the doctor's gonna do the intubation. Don't worry about all the specific stuff for testing. This is something that realistically you're not gonna it's not gonna stick until like you're kind of on the job. And you're working in the kind of floor that would actually have this stuff happen. So I really wouldn't worry about it in the specifics. Just the general ideas would be important. So having the emergency supplies is important. Again, having emergency supplies is important. Restraints, this is so that they don't pull the tube out. So this is important because if you just spontaneously wake up, afterwards, the first thing you're gonna do is like, why is there something down my throat? Why is there a tube down my throat? I'm gonna pull it out. So that's why they do wrist restraints. And then naturally they're going to be sedated and paralyzed. And you want to sedate before you paralyze because imagine being paralyzed and you're still awake. So and you don't need to know the names of the stuff that's used, but if you want to remember which one's which, it's always date before you suck. So etomidate is a sedative, and then the name of this one, succinylcholine, is a paralytic. Getting IV access into them just in case you need emergency medication. Don't worry about a lot of the stuff. Just the stuff that's highlighted. Everything else, again, you'll just you'll just get the general idea. Something that you can do is you can reposition the bed. So you can take away um the bed lock and then move it a little bit out so that someone could be behind the bed because you'll want the best way to intubate would be behind their head. So you can take the headboard part of the bed off and then move the bed a little bit forward so that someone can be behind. Someone can go in behind and then go ahead and do it from there. So then here, I would say the after intubation part, the most important thing to keep in mind is the securing the tape line, the lip line. So how far deep is it? Um, and then just kind of take a look at that chest X-ray to see if it's in the right spot. It needs to be readjusted. And then they have CO2 monitors so that it can tell if it's in the right spot or if it's well positioned because it will detect how much CO2 is coming out when they're breathing. Stuff that makes sense. You're looking for bilateral chest rise. You didn't go in to the right lung or something. Like it didn't go in like directly into one bronchiole. It went more uh so both sides are equally rising. Don't worry about the pivot balloon. It's there, but like, don't worry about any too specific crazy stuff here. Okay, any questions so far? Okay. So your ventilation, you have a few modes here to keep in mind. So you have your controlled mechanical ventilation. This is for people that have no respiratory drive, meaning they are not breathing on their own. The chest X-ray is like the gold standard. They do both, of course. They'll do both, but the gold standard, I guess, is the chest X-ray. This is just like a little piece that gets put in, and the chest X-ray is just like definitive. So controlled mechanical ventilation, no respiratory drive. Because the control it's controlled mechanical ventilation. You are being controlled. Your ventilation's being controlled mechanically. So this setting is for someone that cannot breathe on their own entirely. Assist control, as it's in the name, it's an assist. It's patients that are too weak to take breaths or regular breaths. It's a support. So every breath that's being taken, it gives you support. Um, but I believe this one is also going to make you breathe by yourself as well. So I think AC will also kind of give you force you to do some breaths, but it will still support uh support your breathing as well. The SimV, this one this one will be uh synchronized to your effort. So I believe the SimV will not make you take your own breaths. I think this one is just if you breathe, it helps you. Um otherwise you're good. Let me double check that though. I always get this one confused. Okay. So yeah. So like Maha said, so AC, it will support every breath and it will create its own supporting every breath and forcing breaths. Breaths. So AC will, if you breathe spontaneously, it'll support it, but it will also force you to breathe based on the settings. Your SimV has its own forced breaths as well, but it's not as often. And if you breathe on your own, it will it will allow you to breathe on your own as well. But depending, um, can also assist you. But the SimV will have its own forced breaths, and then it will also allow you to breathe on your own. Yeah. So this one is forced breaths, but will allow for spontaneous breathing unassisted. So the SimV is the one that's used for someone that's getting ready to be weaned off because it allows for your own breathing to go down. Because if someone is on a ventilator, you want to wean them off eventually. You don't want them to be on relying on it. So you want kind of like physical therapy because you want uh you want them to be able to do things on their own. You make them have to do it on your own. You provide some of the support. You'll provide them like a walker, like like kind of going with that physical therapy analogy. You'll give them like a walker and you'll give them some support, but you'll still have them do stuff on their own until they're ready to be without assistance. AC is fully assisted. If they have spontaneous breaths, it'll support it. but for the most part, the AC will have a lot of forced breaths, so the respiration rate will be higher on AC, while on SimV, the respiration rate will be a little bit will be lower because that one you're just those are the forced that rate on the SimV will just be the forced breaths because it's expected that if they're on the setting, they're able to make their own breaths as well. So AC is expected that for the most part, that's going to be most of the breathing is from the ventilator with AC, while SimV, it's expected that the patient will breathe on their own for some amount of breaths. So with AC, you have the higher chance of, I believe it's AC that has the higher chance of hyperventilation because of the forced breaths. Let me double check that though. Yeah, so because the AC is mostly like expected to be the main thing that drives respirations, when you're in AC, you have a higher risk of hyperventilation. Because if you have that one patient that's beginning to improve and needs to be switched and would need to be switched over to a SimV because they're getting ready to be weaned off, that means that they're starting to breathe more on their own. So if you have them breathing on their own and then also the AC, they're still on AC and then having that force them to breathe, that's when you can have hyperventilation. So AC is a higher risk of hyperventilation because of the forced breaths. So if that patient is starting to breathe more on their own, switching them to SimV makes sense. But again, this is all settings that get adjusted and things like that. In a lot of places, you won't be the one dealing with the vents anyways. There's a respiratory therapist that will deal with all that stuff. I'm not so sure about if you're if you're in the ICU, you'll have to manipulate this stuff on your own. But in most floors, you will not be messing with the ventilator other than checking that the settings are what it's supposed to be, and maybe pressing the oxygenation support button. If they're hyperventilating, you would decrease the ventilation on the settings, or switch them from AC to SimV because because the fact that they're breathing more on their own means that they need a little bit less assistance. So because it's basically like if you're starting to see that they're starting to improve on their own, then you allow them to keep putting the effort in so that they can be weaned off because that's your goal. Your goal is to wean them off the ventilator. So if they're starting to improve on their own, you want to keep pushing that improvement. Okay. The CPAP, this is for like this is its own setting, CPAP setting. This is patients that are just entirely breathing on their own at this point. They're just on CPAP mode on the vent. So it's just additional assistance when taking breaths, but that's what that's all about. So I don't think the ventilator has a ViPAP mode, but so this is different from a CPAP. So this is CPAP mode on a ventilator, which is different from an actual CPAP machine. But it's the same idea. I don't think the BiPAP I don't think there's a BiPAP mode on the ventilator, or maybe there is, but it's the same. It'd be the same idea. I believe the BiPAP just helps with the breathing in and breathing out part, extra pressure when you're breathing in and breathing out. Um, but as far as I know, it's mostly just a CPAP mode. And again, the CPAP mode is different from an actual CPAP, but it's the same concept, but it's a CPAP machine is its own thing. This is a mode on a ventilator. And then the settings, I think the main thing for you guys would be knowing this maybe is how much tidal volume they should be getting. I think you'll have maybe a question that uh well you'll have to calculate it. So knowing it should be around 6 to 8 mLs per kilogram. Something you should know. Tidal volume is how much is being breathed in. So how much each breath is giving you, how much oxygen is being taken in with each breath. So if it's too much for that patient, it could cause lung injury because then you're overfilling. The respiratory rate, you still want to hit an overall total 12 to 20. So you adjust it so that if they're on AC and they need breathing almost entirely on to be they need to be they need assistance with most of their breathing, you'll set this higher. If they're on Symphony, you'll start setting it lower because that respiration rate again is a total goal is 12 to 20. You have to include their own respirations into it. So if the patient's breathing 8 times per minute, you'll probably set their respiration rate on their ventilator well, probably the RT is gonna do it, but like maybe around 6 or so they can get like a solid amount of breaths per minute. And as they improve, that's when they get weaned off. They'll start uh being more reliant on themselves than the respirator. But because of the respiration rate is adjustable, you will be adjusting it based on the CO2 rather than based on the O2. Similar reason to like the idea that we work on a capnic drive. So we breathe because we have too much CO2. So you adjust the respiratory rate based on the CO2. So you want the CO2 to be normal. So if it's too high, you might want to turn it up a little bit, or the RT will turn it up so that they can um so that you can CO2 increase the respiration rate so that you can get rid of more CO2. And then with the CO2 being low, you'll decrease the respiration on the settings, or the RT will, so that you're maintaining a little bit more carbon dioxide. And like I said, as the weaning is happening, the the amount of respirations that the machine is gonna give them is gonna go down. FiO2 is the exact kind of like percent of O2 that they're getting. Your goal is to have that PaO2 be above 60, SaTO2 above 90, and the you're trying to hit the lowest possible FiO2 that will get you these numbers because you don't want to hyperoxygenate them. So um, you will be whoever manages the ventilator is going to be adjusting this to hopefully get them at this goal without over hyperoxygenating them. And then here is some signs and symptoms of O2 toxicity. So right here, that's important here. The PEEP is the pressure that's put out. Um, the pressure that comes from the ventilator in order to keep the alveoli open. So it allows you to keep some air in the lungs at the end of expiration, allow the alveoli to stay open. So having this here is good for arts because that's one of the issues is having issues with the alveoli. But it can if it's too high, it can have some consequences like pressure trauma. So too much pressure, you can have some of the alveoli pop from too much pressure. You can have your lung get essentially popped, have a pneumothorax, and a subcutaneous emphysema. This one's you'll see these on test questions. So subcutaneous emphysema. It's kind of like oh, it's like a I guess the best way to describe it would be because the name's kind of confusing, but it's kind of just like little pockets of I think it's pockets of air that kind of show up. Let me get the exact thing on that. I don't think they don't really go crazy on that one. Yeah, it's air gets trapped under the skin. So all that extra pressure has to go somewhere. So you have air getting trapped under the skin under the subcutaneous fat. And when you touch it, it feels like you feel crackling like when you touch it. But yeah. And then this is the difference between the PEEP and the pressure support is like when it's occurring. So end of expiration versus pressure support, which is during inspiration. So PEEP is the pressure that stays so that you still have a little bit of pressure as you're breathing out to keep the alveoli open, while pressure support is a little bit of extra pressure as you're breathing in. And I know that's a lot of information. I know that this is probably confused. Like, when do you do the pressures? When do you know to change the pressure support? When do you know to change the PEEP? You're not going to get tested on it, and you probably don't ever need to know that because I'm not sure about an ICU, but at least most floors, the RTs will do all that stuff. So your responsibilities is knowing the goals of care, knowing like what's the purpose of of the setting, knowing what the prescribed mode and settings are. Yes, baro meaning pressure, trauma meaning trauma. Yeah, so excess pressure. So too much pressure, too much PEEP, too much pressure support too can cause pressure trauma, damage from the pressure. Like in general, yes. Just barotrauma in general just means pressure trauma. Like here, it's happening in the eye from Here it's happening in the eye from ocular pressure. So it's just general. But in this context, it's referring to too much pressure from the PEEP or the pressure support, maybe popped an alveoli or causing some of that excess air to start leaking into the skin. Okay. So I think your main goal is really just knowing the mode and settings. Is it correct? Sedation goal. So they're going to be sedated. So you have a goal, a RAS goal. If you remember your scale, you don't have to hard memorize the scale or anything, but as long as you're able to utilize it. So you'll have like a prescribed like sedation goal. So as long as like let's say like they'll tell you like they should be on RAS, your RAS goal is to be -2. So you will follow just like this scale and then titrate your propofol so that you kind of get to that level. So when you're in the ICU, you're titrating propofol, you're titrating the vasopressors and all that stuff. Actually, I'm gonna look up if the ICU nurses actually like directly mess with the fence. So I imagine it's still the RT, and then you just no, yeah, it's gonna be mostly the RTs. Yeah, the RTs are gonna manage your vents realistically, and the ICU nurses will just monitor them, keep track of that they're in the right settings, and watch out for pressure alarms, which is something that you will be tested on, the pressure alarms. Okay. So sedation, they're on sedation, so they'll have sedation holidays, just like what you guys learn in the VAP settings, and then vital signs. I believe vital signs in general are Q15 there, but they're also continuous and automatic, so that's a thing. They're on restraints. Oh yeah, that's good. They're on restraints, so you're just doing your CMS and skin integrity, and then the ventilation assessments, high or low. Uh, did she not? Okay, we have like a whole section on alarms. Okay, cool. The skin. So the tube, I think, can be repositioned sideways, like left to right. And you want to reposition the tube to prevent mouth injury. You don't get tested on that, but I guess that's a thing that Kaylin saw in the ICU. And then there's just a refresher on the VAP bundle. Okay, how much more we got? Okay, we're almost done. So alarms. First thing you check with the alarms is the patient and not just the alarm. So you want to see like how is the patient doing? Sometimes you'll get a high pressure alarm because they're coughing. So um, if they're coughing, you check the patient, check the alarm, go back to the patient, and kind of see where you go from there. Sometimes the patient is biting on the tube, so you might want to reposition. Depending on how sedated they are, what their sedation goal is, maybe you'll have to try to calm them down, or maybe they need to be more sedated with their propofol, like to titrate their propofol, or you can bite blocker. So high pressure, the pressure alarms, there's high and there's low pressure. High pressure, kind of like in the name, is something blocking something or something obstruction of the air going in. So coughing is an obstruction, biting is an obstruction. secretions and stuff in the tubing is an obstruction, something that gets in the way of the O2 getting through. So that's the kind of stuff you think about with the high pressure alarm. You'll have water collection in the circuit, so you have to empty that. So you want to drain the water so that doesn't get into the airway. Do suctioning to remove secretions. And then here it's just another thing that could be causing the high pressure is a pneumothorax. So that's something that could also happen from the barotrauma. So that's why you want to, I guess the RT, I guess, wants to be careful with all this pressure support because they want the pressure support, but you also want to be careful not to do too much because if it's too much pressure, it could puncture like you could do like a spontaneous pneumothorax, and that's when you'll get a high pressure alarm because the pneumothorax is meaning that the lung isn't able to properly uh obtain the oxygen from the ventilator, which is why the high pressure alarm goes off. So that's why you want to check your patient first. If they're looking like they're fine, well, relatively speaking, they're fine. Very relatively speaking, they look fine because it's the ICU, but relatively speaking, they look fine. Then you probably expect that it might be one of these other causes. But if they don't look like they're fine, their chest isn't rising evenly, that's when you look at the possibility of the pneumothorax. And then the low pressure alarm is due to things just not being connected properly. There's a leak somewhere, which if you can't determine where the leak is, then they're not getting any oxygen. So, if you can't determine the cause of the alarm, have you want to get your ambu bag that should be at bedside and then back them while you ask for more help. I think at this point, you just call for help because the ICUs are at least the ones that I guess Kaylin has seen. I've actually never been in an ICU, so I don't really know. But from what I hear, they're usually kind of tiny and kind of cramped together. Uh, so that the nurses can monitor the patients through the glass sliding door from the nursery station and be really close by whenever they need to. And then also they can call for help whenever they feel that they need to. So in that situation, you just call for help, start bagging them, and then go from there. And then again, we've been talking about how they want to be weaned. Um, Here's some weaning uh guidelines, but I really don't think that it's something that they test you on like hardcore. It's literally just kind of like understanding the general trends. Like if their O2 levels are uh like decent, then it's fine, right? If their O2 is under 90, they're not ready to get weaned. If their blood pressure is crazy abnormal, then they're not ready to wean, if not ready to be weaned. If their heart rate is showing signs of compensation, they're not ready to be weaned because this is all while on the ventilator. So if they're on the ventilator and their O2 is not stable, that's a problem. Their heart rate and respirations are showing that they're compensating. That means that they are not real. I mean, it means that they're not tolerating it. So if they gave you an example and you can tell that they're clearly not tolerating based on the vitals, that's enough for you don't have to hard memorize all these numbers. It's just make that judgment call. Like if you have someone with respirations 16, SaTO2 at 94%, heart rate of 82, blood pressure of 130 over the 70 something, all those vitals look solid. They're ready to start getting weaned and they're ready to go on to the next level. If their vitals are looking off, then they're not doing well and they should not be they should
we should backtrack the weaning. Patient should not be struggling. Okay. So signs of intolerance is what I would focus on because like I said, you guys are smart. You guys can tell from the vitals if someone is not tolerating their weaning. And then they also have spontaneous breathing trials where they will just full on turn off the ventilator and then see if they how well they can tolerate sitting up and breathing on their own. They'll do an ABG just to see how they're doing once they're already like breathing on their own at this point. They still have the tube in place because just in case it doesn't go well, you want to have it still be there so you can just restart it. But um, they can do an ABG and then see it. From the PowerPoint, it just said good results, but it basically it's just looking for more stabilized ABG, so not crazy metabolic sorry, not crazy respiratory acidosis or alkalosis, just like normal or compensated or maybe very slightly respiratory acidosis. But as long as it's not crazy abnormal, it's fine. And again, pretty vague on the hemodynamically stable, but general idea stands where it's like just don't memorize the exact numbers. It's just based on that judgment call. And then here's some of the stuff that's done prior to extubation, but it's not something for you to hard memorize. I would focus more on what is done after extubation. So monitor the patient very consistently. Uh, they're off the vent, but that doesn't mean they can't get supplemented with O2. They can go on a nasal cannula. Assess for stridor because they've had a tube down their throat this whole time. There's a possibility after it gets removed that it starts to swell. Their throat will start to swell. So that is the important thing for you to keep track of. So very much you're assessing them very, very often for every 5 minutes or more. And I guess in the ICU they have sliding glass doors, so they can just kind of do it from the bedside, but check up on them. And then some of the stuff that usually follows a lot of the post-op. So turn-cop deep breathing, early ambulation, set of spirometer, all that stuff. And their throat will probably feel sore, so a cough drop, lozenge for pain, all that stuff. And right here, this is like extra information on medications. So again, here's your RAS scale. You don't need to hard memorize it. Just know that the negatives mean that they're sedated and the positives mean they're more agitated. So obviously, regardless, your goal is for them to not be agitated. You're gonna want them to be either at zero or maybe up to whatever you're maybe up to like -3 or something. -3, -4. Depends on what your order is for the sedation. Definitely don't worry about any of this dosing stuff at all. This would be like ICU only stuff. Don't worry about any of that. Again, all of this is extra info. None of this at all. Like you do not have to worry about any specifics on propofol. You will, they will use propofol in the ICU, but you are not tested on it. It's just extra info for those that are interested. So the whole thing is extra info, okay? But if you're interested, here's some info on propofol, some some extra info on Versed and on fentanyl. Okay, so propofol, I believe it's a fast onset, which is also it has the fastest changes, so very good, very titratable. And you can it's easy to titrate down and have the effect be faster than some of the other ones. So Versed is a benzo, so it does have a reversing agent. The Romazicon is a reversing agent for any benzo. And then fentanyl is an opioid, so the Narcan can be used if of overdose. So that's the good thing about using either of those two for sedation is that they have reversing agents, or with the propofol, it's very sensitive to titration. And then I have some questions. I guess some of the answers are highlighted. I'll unhighlight them. I think this one just you guys can go over it on your own. Do you guys have any questions on respiratory? Because I figured there's gonna be a lot of questions, but if you guys have any questions now, go ahead. And if you have any questions later, you can just pronto me, and I'll answer it whenever I'm available.